Well, I think the main task here is to show you some interesting information which will tempt you to go and read the chapter, which inevitably will contain a lot more and will lead you through this topic, which I suppose it shouldn't really surprise us as being so important and relevant to the airway. If we look at these data from the Information Centre for Health and Social Care, you can see that the adult population, about when we did this study or the project, about 24.5% of the adult population were obese. And it's slightly higher in females than it is in males. And if we look at morbid obesity, the BMI of over 40 or 35 plus comorbidities, we'll find that it accounts for about around 2% of the adult population. These figures apply to adults. And within NAP4, the obesity complications that we observed, of the 184 reports we received, 77 were of obese patients. That's 77 from 25% of the population. And of the 133 anaesthesia reports, 53 were obese. Down here we had the anaesthesia reports, and these are the reports as a whole. And what is striking is that there were 53 reports from anaesthesia and 77 from as a whole, but there were relatively few deaths in the anaesthesia group and a much larger number from the reports as a whole, representing the impact of being obese on the ITU and in the emergency department. Down here we see the emergency surgical airways, and they're relatively common in this group of patient, and I'm not sure whether it's statistically significant. The failure rate was higher than of the group of emergency surgical airways as a whole. So obesity represents a significant challenge with regard to the airway. I'd just like to look at the BMA data that we have on that we collected, and we didn't really set out to study BMI in any particular detail. So we have somewhat arbitrary limits of less than 20, 20 to 30, over 30, and over 40 was not one of our fields. The BMA, we set definitions of cachectic, normal body habitus, or obese, and I've adopted these because they are because I felt they fitted in with those definitions. But if we break the reports down into less than 20, 20 to 30, and 30 to 40, and most normal or overweight people would fit into this category, you can see that the reports from those patients over with a BMI of over 30 are similar to those in the range of 20 to 30 if we take out the cachectic group. And if we just explore that a little bit further and remove these from the equation, we have, if we look at all reports, we have 89 in the normal to overweight group, 77 in the obese group, and then if we remove children from the equation, because the definition of obesity with a body mass index of more than 30 applies to adults, there is a different system for selecting children. If we remove those, we find that approximately these two categories are about the same. So 25% of the population had the same number of complications as 75% or 70% of the population. Those patients with a BMI of over 40, which are also included in this group, represent 2% of the population. They had 8% of the complications. But if we compare that group to this, you see where we have 70% getting 45% of the complications. You see relative to those who are normal or overweight, the incidence of complications in the morbidly obese is much higher. it's more than the initial assessment of 4 times, I would suggest. And actually, the story gets even worse than that. Because when we set up the NAP4 project, the fields that we made available were a cachectic, normal body habitus, or obese. And not all forms included the information on body mass index. And so there will be obese patients who are simply reported as being obese when actually they have a BMI of more than 35 or more than 40 or more than 35 with comorbidities. So the number in that morbid obesity group is actually, we're missing some. So it is it's a lot of complications seen in a very small group of patients. Now, I don't need to run through these, particularly as it's getting late. We all know that obesity is associated with comorbidities, aspiration risks. There are well-documented potential airway problems. They've got increased oxygen demand, reduced oxygen reserves, and there are alternative techniques available. They don't need general anaesthetics. You can use regional anaesthesia. They may require an awake intubation. There are alternatives with regard to supraglottic airway devices. So we do have choices when we're managing these patients. Let's look at the Obesity and Anaesthesia reports. There are 53. 50% were female, and this represents an over-representation of females because we know that males are 50% more likely to appear as reports in NAP4. But because more of the female population are obese, it probably accounts for the reason that there is parity. Surprisingly, the obese patients tended to be younger, more towards middle age than the general population of NAP4 reports. Comorbidities were common, and in particular we saw a lot of hypertension or ischemic heart disease, but also obstructive sleep apnea. And when we go through to look at some of the clinical reports, obstructive sleep apnea was apparent in 17% of cases, and these don't come as any great surprise either. What did surprise us looking at the reports was, paradoxically, the reports coming in on obese patients showed that there is actually a lower consultant level of input into the management of the obese patients who presented to NAP4 than in those reports from non-obese patients. So perhaps there's a degree of complacency about that. So the important thing that there were certain areas that popped up or cropped up when we were reviewing the obese cases, and these are the sort of problems that were more common in the obese group. LMA and supraglottic airway device problems were more common in the obese. And what is actually surprising was that relatively SADs and laryngeal masks were used as commonly in the obese as they were in the normal population, when one might have expected them to be used more rarely. Failed mask ventilation was common in this group, as you might expect. There were also problems with difficulty in intubation, airway trauma, and problems at emergence. But there was one group that also stood out amongst these, and these were the patients who required conversion from local anaesthesia or regional anaesthesia to general anaesthesia in NAP4. There were 5 patients who required conversion due to either inadequate block or prolonged duration of surgery or inadequate anaesthesia, and 4 of those patients were obese. So there was a higher conversion, or it may be that regional anaesthesia was used to avoid the airway problem, but when airway problems develop, or when general anaesthesia was needed to retrieve a regional or a local anaesthetic, this was where some anaesthetists got themselves into trouble, which is something that we'll be coming back to a bit later on. These were the areas of concern. In particular, we are going to go through them in order: assessment and preparation, regional anaesthesia that I've just touched on, awake intubation, underused, supraglottic airway device use I've already touched on, the way general anaesthesia was conducted, and organisational factors. I'm just going to run through some of those now. But I'm going to use a couple of case reports to illustrate this particular problem. Here we have a patient who has already been presented to you, a male of 150 kilos, he had obstructive sleep apnea, hypertension, ischemic heart disease. He required minor hand surgery, and I don't mean that it was a hand operation, it was minor hand surgery that could easily have been done under a local or regional block. But he was needle phobic and required a general anaesthetic. He had an apparently straightforward anaesthetic, but at the end of the procedure he removed his own laryngeal mask. Airway obstruction developed, he had a cardiac arrest, resuscitation, ICU, tracheostomy, but apparently he made a full recovery. He was discharged after 7 days. But this illustrates what full recovery involves in some of our patients who've had airway problems. And I'd just like you to run through this next case, which is again male, morbidly obese, reduced palatal view, because the framing of the questions in our form suggests that the Mallampati view was impaired. He had limited neck mobility. He required urgent surgery, which could have been performed under a regional block, perineal surgery. After a brief period of pre-oxygenation, a trainee anaesthetist gave him an IV general anaesthetic. It was difficult laryngeal mask insertion, difficult bag mask ventilation, probably esophageal intubation, cardiac arrest, failed resuscitation and death. So I put those up there because they're actually quite similar, and they do illustrate some of the points that I'm coming up to now. The assessment and preparation, comorbidities in this group were common. This is something that we've heard repeatedly over the course of the day. Signs of airway difficulty were absent, but airway assessment wasn't performed in about 30% of these cases. And equally, particularly as with the second case that I showed you, when problems were obvious or likely, they were ignored. And we've seen other reports where there were clear evidence of potential airway problems that did not lead to a change in behaviour. Now, in the second case, and the first for that matter, local or regional anaesthesia was not used or not considered or not discussed. Well, perhaps it was discussed, but perhaps we need a bit more. We need to have a stronger, more informed discussion with these patients to encourage them to move towards regional anaesthesia. There were other examples where the inappropriate techniques were used. It may well be that tonsillar biopsy under local anaesthesia with heavy sedation is a mainstream technique elsewhere. There was a report of this to NAP4 in an obese patient who developed airway problems and needed an urgent surgical airway. But it suggests that in this group of patients, inappropriate techniques are used to avoid tackling the airway problem. Similarly, there was a report this morning of an obese patient who had hand surgery with a failed regional block. If you're going to use a regional anaesthetic to avoid managing the airway problem, then you may need a plan to deal with failure of the block, it's a part of the joined-up thinking of thinking the patient's problem through to the very end. Because if you need to convert to general anaesthesia intraoperatively, that's potentially more hazardous than securing the airway at the outset. And Suk's talk this morning has covered awake intubation was not used in a number of cases where it was an obvious technique for a very suitable patient, and he showed some examples of that. And there are other examples where it failed. And one of the things that he focused on and talked about was problems with sedation. Conduct of general anaesthesia from this group of patients was less than ideal. There seemed to be poor anticipation of the airway problems, which maybe relate to selection of devices and of techniques, and preparation was poor. For example, there was poor preoperative pre-oxygenation, and it may well be that there was poor planning of a response should difficulties develop. Now, there were inappropriate techniques used in this group of patients. We've seen reports over the course of the day of spontaneously breathing patients in lithotomy or Trendelenburg in obese and morbidly obese patients, and perhaps that's something that has compromised some of these patients. Supraglottic airway devices were used as commonly in the obese patients as they were in the normal population, and I'd suggest that this is inappropriate patient selection, and there, as we've heard earlier, there were other devices which might have been more appropriate. At an organisational level, we've heard of day cases. We saw reports of day cases of patients who were morbidly obese with BMI of 150 coming in for minor procedures as day cases. And so the organisation doesn't really, our hospitals don't accept that morbid obesity is a significant risk factor, and that leads to poor communication of difficulties. We have documentation of obstructive sleep apnea not reaching the anaesthetist, insufficient times allocated for assessment, and of course if the decisions have been made about the operating list, it's very difficult to turn around in the middle of a list of 10 patients and say, well, we're going to have to do an awake intubation. So organisational factors were a common problem, which meant that patients were anaesthetised in inappropriate locations, such as daycare, and perhaps with inappropriate anaesthetists, again, as we saw with reports this morning. So I just want to pick up on a few of the most important areas. I think there needs to be a greater level of awareness at an institutional level that obesity is a significant problem for the anaesthetists. And I think that one of our recommendations was that morbidly obese patients require a thorough preoperative assessment at a time without time constraints in advance of the procedure, so as the options can be discussed, and if they require a specialised technique, help can be recruited or this can be arranged. Now, when, as part of that assessment, as part of the joined up thinking of creating a strategy rather than a plan, the airway assessment should include the feasibility of rescue techniques, such as how easy it is to locate the trachea and perform an emergency cricothyroidotomy or an emergency surgical airway, and that should be an essential part of the assessment of these patients. And when things are done under regional anaesthesia, there needs to be, everybody involved needs to understand the problems that may be involved if you need to convert to general anaesthesia with these patients. There are more recommendations in the chapter, but this is pretty much a summary of where we've got up to. Thanks very much.